Okay, it's 12:03. Should we just start with introductions?
Yeah, start the introductions and more people will probably jump on too. That
Right.
often happens.
It's still happening. So, hello everyone. I am Sue Mintonen, part of the NAMI on Nantucket team, and I welcome you to the October Behavioral Health Advisory Group meeting. And I think we'll just go around and introduce ourselves and where we're from in terms of behavioral health on Nantucket. Suzanne, would you like to go first?
Sure. Suzanne Franzuto, NAMI on Nantucket.
And Jackie?
NAMI on Nantucket, Executive Director.
And Amanda?
Amanda, Clinical Director at Fairway.
Laura?
I'm Laura Sigrist. I am part of the GPS team here today to share findings from the behavioral health assessment.
Jericho?
Hello, Jericho Mealy, Director of Human Services, Nantucket.
Elise?
Hi, Elise Norton here, Program Manager at the Nantucket Family Resource Center.
Erin?
Hi, Erin Russell. I'm the Outpatient Director for Nantucket on Gosnold, at Gosnold.
Thank you. Alexandra?
Hi, everyone. I'm Alex Foley. I'm the new CSAT case manager and forensic interviewer at Children's Cove. So I'm just here to say hello, Christine.
Great. Thanks to have you. Thanks for coming. Christine?
Hey everyone, I'm Christine Montero. I'm the mental health coordinator at Children's Cove, and Jacob Stapleton has been regularly attending this meeting and asked us to sort of jump in and cover for him today. I was previously attending when the meetings used to be in person, so I'm glad to be back to the virtual one. Thank you.
Great. Welcome back. And Nancy?
Hi, I'm Nancy Vandemark. I'm working with Laura and the GPS team.
Janine?
Did you mean Jean?
Hi, everyone.
Yeah?
Yes,
No.
my name is Janine. I'm a private citizen very interested in mental health. My husband is a psychiatrist and has been for 30 years. So I like to attend these meetings. I do fundraising and happen to know a few donors. So I'm just following this whole process and that's it.
Great. Thank you, Janine. Amanda? Other Amanda?
Hi, hi everyone. I'm Amanda Consigli. I'm the public health analyst for the overdose response strategy for the entire state of Massachusetts. So I'm not in Nantucket, even though I'm very jealous. But my role is to help communities reduce overdoses. And of course, we know there's a huge connection between mental health and substance use disorder. So I'm excited to hear what you guys are working on and what you found with your needs assessment.
Great. Thanks for being here. Sherry?
Hi, I'm Sherry Flint. I'm the director of the Elder Service Office here in Nantucket.
Chris?
Hi, everyone. Chris Glowacki at the hospital.
Jean Miller?
Hi, I'm Jean Miller. I'm from the Community Foundation for Nantucket. I'm joining because I've recently been charged with kind of herding the cats on the new Behavioral Health Assessment Initiative leadership team. So I want to hear what the report has to say. And I'm not showing my face because I just worked out and didn't plan on doing this, so it's last minute.
Carrie Ann?
Hi, I'm Carrie Ann Letty, and I am just a community member at this time.
Thanks, Carrie Ann. Sarah?
Hi, everyone. I'm Sarah Chakowski. I am the Social Services Manager at Nantucket Cottage Hospital.
And currently, last but not least, Brian?
Hi, good morning. My name is Brian Linney, and I work for the Nantucket Community School.
Great. That is everybody who is logged in. So welcome everyone again. Jackie?
All right, a couple of things. As I said, Kevin is among the missing today because he's in Washington, and I'm going to fill in for him. Big job. And I do want to make one announcement, and then I'll introduce our speakers. I'm going to actually be on island for the first time in quite a while next Wednesday, and I'm giving a presentation at the invitation of one of the churches at the Hadwin House at noon. It's a brown bag lunch affair, and I welcome everyone to be there. We're going to talk about mental health on the island. We'll review a little bit about what is said today, plus we'll talk about the expanded services that we have planned for the island. And so please spread the word. You'll see it posted here and there, but I would love to see anybody that wants to come and learn more about what NAMI has planned for mental health. So now I'm pretty excited that we were able to finally get the first part of this work done. And the first part of developing a plan for mental health on the island was first to determine as scientifically as possible what was needed on the island. I think we all had a good idea what was needed just from our everyday experiences, but we needed to verify that and to come up with a report. So GPS was engaged to do that. It's a 3-person team, and the assessment has now been completed. So we'll be ready to go into phase 2, which is starting to act on the assessment. And today we're lucky to have both Nancy and Laura here to present the assessment as it has been published. And also, I hope there'll be time for Q&A, because this is a good time to ask them questions about how things happen, things that you feel might be omitted or you don't understand. So please, I want this hopefully to be somewhat interactive at the end. So Nancy and Laura, can you take over now, please?
Absolutely. Thanks, Jackie, for that introduction. It's really great to see your faces again. We've had a chance to talk with, I think, most of you at some point over the course of the last couple of months. So thanks for coming today. And what Nancy and I are going to share with you is really essentially, we've got 10 pretty densely packed slides. We promise not to read them to you. But it is essentially the executive summary of the much longer full-length report. So there's a lot of detail and finer points that are embedded like further down in the document itself. And a word about the document, I don't know yet that it has actually been published, but it should be available very shortly, pretty soon. And we'll talk a little bit more about how to access that here at the end of the session. As Jackie said, we'll welcome lots of dialogue and Q&A. I think we've got an hour booked on your agenda. Our presentation will not take the full hour, so we wanted to make sure we had lots of good time to chat with you. All right, so let me share my screen here. And let's just dive right in. And one thing I will note, we've got a couple of caveats here on the report. And again, the font is tiny. Don't expect you to read any of this, and I will not read it to you either. But a couple of caveats as you're listening and as you're scanning what the content you see on the slides today, and as you get access to the full report later, here's a couple of things we want you to keep in mind about what's in here. When it comes to the data itself, we fully own, this is not an academic nor an epidemiological study. We know that that's been a priority of NAMI's, is to get an epidemiological study going on that. And this is not that, and it doesn't replace that in any way. But we have integrated any data that we could get our hands on, both for services on the island, prevalence on the island, things that are happening across the Commonwealth, and things that are happening across the nation as well, to help make the case. We also know that sometimes when we do that, the timeframes are not necessarily apples to apples. So we may have a year span that leads us up through July of 2020, and we may have another time span that leads us through December of 2020, and that's okay. So we've made notes for that, and where we were not able to do a proper comparison, we've noted that for you. We know sometimes we also had point in time data. Sometimes that's the best we get, especially in the behavioral health world. You might just get what you get when you ask the question on that day. And the last thing I'll say about the data is that sometimes the official validated data sources, they lag by a year, sometimes 2, sometimes even 3, as in the case of one report that we'll share with you here in just a couple of minutes. So we know that the full impact of the pandemic sometimes is going to be undercounted and underrepresented. And we all know, and you all know very well, that probably the numbers and things we'll share with you today likely influenced fairly heavily by the pandemic. So just keep those things in mind. The other thing that I want to point out is that we've done our very best to point out issues or share concerns, highlight challenges in the behavioral health system on Nantucket, but wanting to ultimately be very respectful to the people who are both needing and receiving services and those who are working very hard to provide them. Okay, so we just want to say that right up front. We're respecting everybody. And the last thing is, we heard many heart-wrenching, very personal stories of challenges and struggles and experiences. And so we want to pause and take a moment of gratitude to thank you, your friends, your families, your neighbors who are willing to share those stories with us. And we want to make sure that we note for you, we've not created any personal details, we didn't share any personal information here, but all of those personal stories really help us understand and help validate what you feel, which is this sincere need for urgency. You know, we've got the community on board, we've got to rally around really integrating the behavioral health system of care. Okay. All right, so Jackie covered this for me, so I can go through this part very quickly. As she mentioned, this is the first phase. This is the culmination of the first phase of a multi-phase effort. And just a sense of how we got to where we are, how we got the information in the report, where did it come from, and how do we pull it together. So we started back in the spring. It has been just about exactly 6 months. And we ultimately followed a fairly rigorous process of community engagement as deeply as we possibly could get. So we held 9 community focus groups. We did a whole bunch of interviews, lots of small group meetings. A lot of you were in those with us a lot. We also did a pretty big community survey. And so in total, we engaged face-to-face, or I like to say screen-to-screen, with about 112 people in a small group or individual setting. And then from a survey perspective, we received 175 responses from the community to our survey, and we received 13 responses to our provider survey. And one thing that we'll note here, and this will come up again a couple of times, we want to be really clear about this. We only really received 3 Spanish language surveys and 3 Portuguese language surveys, despite lots of creative efforts, despite lots of help from lots of you here today. And we know that there are nuances in the needs of these specific communities, and they just don't show up in this report like they need to. And so we recognize and honor that we didn't get to those communities in a meaningful way. And that's important as any work moves forward, to be very intentional about creating channels to do that in a better way than we were able to. So with that caveat aside, we took all of that community input into account as we built this report. Lots of you on the phone here, lots of others in the community and other places around the state deserve much gratitude for your help in sourcing data, explaining how things work, sometimes more than once, highlighting gaps, proposing solutions, coming up with really good ideas. We've worked really hard to be faithful to what you all shared with us, but we also offer some options and ideas from beyond the community as well. Okay. Let's move into a little bit of the details around why we were motivated and understood and trying to understand sort of the background and the basis for looking more deeply into the behavioral health system of care on Nantucket. One note about population, the 2020 census data came out right in like the very end of our detailed work. So right there in the middle of August. And revised data shows an official population of about 14,000 for Nantucket. We know from other sources that that's probably still low. So we relied on data from the Nantucket data platform, utility, transportation metrics, those kinds of things, that the year-round population is closer to somewhere between 17 and 22,000. We erred on the caution side of that range. So for most of our population numbers and comparisons and ratios, we use that 17,000 number. Okay. So let's talk a little bit about Nantucket's history with suicide, which you all know much more deeply and intimately than we ever could. So we didn't dive too deeply into the history of the clusters on the island, although we're well aware of them. We wanted to look and see what was being published out there in the world. And the Massachusetts Public Health Department report came out last year. It's a 2020 report that compares county by county suicide rates, and it lists Nantucket as having the highest suicide rate in the Commonwealth. And that is based on a population and an incident rate as well. Now those numbers are based on 2017 data. So again, we've got a pretty big lag in the data. And we also know that the effects of the pandemic, when they do their next report, we may see something even stronger. When you pair that information from sort of the state level bird's eye view with information that gets self-reported by your students and your children as part of the annual Pride survey, the picture gets more crystallized for us. So we looked at the 2018-19 Pride survey, which again is the most recent year available. They didn't do one last year. They're hoping to do one this year, of course. We looked at a lot of different characteristics, a lot of different data points, and a lot of different values. And the things that we wanted to share with you today to draw your mind and attention to is that in the self-reported data, and I'll say that again, it's self-reported data from students in grades 6 through 12, that information shows that there were 41 kiddos who are at risk for suicide. And that is defined, and it's important here to understand how it's defined in the report. These are kids who are self-reporting that they are thinking about committing suicide a lot or often, okay? And those 41 kids represent a 34% increase over the same data point from the year before. Pretty significant uptick in that. When you dig deeper into that data, the largest percent of those kiddos were your 11th graders and your 6th graders. The same report showed fairly significant increases in substance use for marijuana, illicit drugs, alcohol, and hallucinogens. And again, I'll say it one more time, these are self-reported statistics. This is the kids who are reporting their own usage and their own risks and attitudes. We also know that data from A Safe Place show that during the pandemic, there's been a 30% increase in demand for services related to domestic violence, and a 20% increase in demand for services connected to sexual violence. There are other statistics that validate what the island's families and providers feel. And one of those, obviously and clearly, is the sense that it is sometimes it feels hard to get connected to a behavioral health provider, and sometimes it feels hard to stay connected to a behavioral health provider. We'll talk more about the provider capacity, provider density in just a few minutes. It's important to put some data framing and comparison data around that. But succinctly, when you look at the provider to population ratio in Nantucket and compare it to other counties in the Commonwealth, that provider to population ratio is the worst in the Commonwealth, and particularly so when compared to neighboring counties. It's further exacerbated by turnover, challenges in recruiting, challenges in retention, and all of those things fueled by some other underpinnings on the island. Nancy, I'll turn it over to you we'll talk about crisis.
Sure. So in addition to the challenges that Laura identified, the lack of, we heard about the lack of access to routine behavioral health care, and that this results in unnecessary crisis and emergency room visits, and in some cases, transportation off island for inpatient care. So there's some unique challenges that that the lack of access to routine care or providers, generally provider availability, seems to be driving in the crisis system. And then also that, as with other parts of the Commonwealth and the country, the social determinants of health, it seemed to increase the stress on Nantucket, in particular in the area of housing costs. So housing costs is probably unique, certainly unusual in terms of the magnitude of challenge that presents around access to care, access to recovery, and sort of the challenges that people face. In addition, we heard that people remain in community survey data that people remain fearful, and actually the fear of accessing care is exacerbated by some of the both the stigma related to mental health and substance use problems, but also the fear that someone might find out, and that that this may result in, for people who are undocumented, an encounter with law enforcement or in fact deportation. So that fear is a salient issue.
Thanks, Nancy.
That's it for me.
Thanks, Nancy. Let's talk more about the providers. I've got a couple of slides here because it is such an important point. So we know that Nantucket's got a collection of both organizations and individuals who are providing behavioral health services in a range of services. We know that we've got organizations who are often delivering on separate, sometimes non-integrated missions, and yet they are dedicated and they're committed to doing as good and as quality and high work as possible. We've got, by some counts, by most counts, about 17 or so regular established private providers. Some of them are fully remote, providing service. And we know that there is some number of telehealth providers. You know, when you go searching for a telehealth provider who provides service in Nantucket, the world opens up very broadly. When you go to try to make an appointment with one of them, sometimes you run into challenges with actually getting access. So the telehealth world has both been, I'd say, a boon and also a bit of a challenge in actually understanding provider capacity. We've also got about 6 or so primary organizations who are providing behavioral health services, very well known to you. Some of you are from those organizations here today. Some of these orgs are providing direct treatment and care. Others are providing referrals and educational resources. And so we talk about and relied a lot on data from these 6 listed here on this page very specifically: Fairwinds, Gosnell, the hospital, Addiction Solutions, Safe Place, and of course NAMI as well. And yet, despite sort of this body, this clutch of behavioral health providers, access still remains a challenge, and certainly at least in perception, if not in reality. So something interesting that we learned about that variance in perception of access to services came through in our survey. So in the provider survey, we asked providers to tell us, you know, how quickly can you get people in for an appointment? Do you have wait lists? Those kinds of things. And we heard from the providers, you know, we can get people in mostly the same day, 48 hours or so tops. The community said, though, we're waiting for a month, sometimes more, or every time I try to get in, there's a wait list. Or I can get an intake appointment right away, but actually getting an appointment with a provider, that might be weeks out. So despite the fact that people are working very hard, and that this is not the instance every time, the community perception is that services aren't available and they don't feel like they have access, even if maybe they do. Okay. And when we talk about really enhancing system integration, system coordination, system collaboration, this idea of driving a much better and deeper understanding and mutual awareness of system-wide capacity becomes really important to really understand, what do we have capacity for? What kind of hours are we looking at? What's our caseload on a much grander systemic scale? Let's take sort of another one level up on providers again. So a quick primer on the data that we use to build the chart here on this slide. Much of this comes from a data effort run from the University of Wisconsin Population Health Institute. And let me tell you kind of what you're looking at here. We're looking at the provider ratio. And when we say provider ratio, we mean the count of providers as compared to the total population. And that's a way to compare different jurisdictions to each other to understand sort of the density of providers in a given location. And so when we talk about one provider, if they were going to see, if the entire population were going to be served by providers, if everybody were going to go into behavioral health care, one provider could see X number of clients, okay? So what you have here on this chart on the left-hand side is the statewide, this is Massachusetts data, and then a couple of neighboring counties. And you've got two bars here for Nantucket, and here's why we included both bars. The yellow bar there right in the middle uses that census population estimate, that 14,000 person population estimate, and a total count of providers from the National Provider Identification Registry that's administered by the federal government. And we think that we know that the population is underrepresented, and we also think that the provider count is overrepresented based on the survey of how many providers are providing services, who's available, who's actively participating in playing in the provider field. So the red bar, which shows a much higher provider to population ratio, which again, the higher number you get, the worse it is, we feel is a more accurate representation of the provider to population ratio on Nantucket. That uses that revised population estimate and a more finely tuned count of providers on the island. Okay. This matters here because when you look at your neighboring counties, you look at the statewide number. And by the way, the Massachusetts number in this set of data is the best in the country. It has consistently been the best in the country for many years in terms of looking at the number of providers and the population. We did take a deep dive into state licensing data to get a good count. We also took the approach of someone who would be seeking services to understand what it might feel like to get connected to a provider. We're trying to research who's available, try to find someone who fits, try to understand how to get an appointment made. And in some cases, we ran into conflicting information or outdated information. And so we both had this sort of like, academic or numbers-based perspective on the challenges with provider density. And then also, again, just that real life connection point. And there are real challenges there. The bottom line really with the data on this page though is this. The Commonwealth, as I just said, is an exemplar in the country. And yet Nantucket itself has a ratio that's significantly worse than many counties across the nation. It is not the worst county in the nation, but when we've got Nantucket situated in the state that has the best ranking in several behavioral health access indicators, this makes this provider access issue feel particularly challenging. We also know that to shift the ratio for Nantucket to be closer in line with neighboring counties, it's got to be somewhere like adding something on the order of 20 to 25 providers to the existing workforce. That's a lot. That's a lot of humans. And we know there are a lot of real life challenges with doing that. Nancy mentioned some of those right off the bat, just getting people on the island, keeping them there, housing costs. We also know there's other ways of doing that. It doesn't have to be 20 individual humans coming on board. But when you look at a number to number, a county by county comparison, it gives us a pretty stark picture. And again, we can feel this and you all can feel this too. We heard this from your community. We heard this from you when we talked with you about capacity, accessibility, wait lists, referrals, and resources. Okay. So let's talk a little bit more about the specific gaps that we found and that are further detailed in the full report. Nancy, you want to share a little bit about this, this subway map chart?
Sure. So this is an overview of the 15 gaps that we identified across the continuum, and they're organized around the 4 categories that I think we discussed in this group early on: prevention, which is getting ahead of problems; intervention, which is trying to get something, a service to someone at that earliest point after the problem emerges; treatment, which is responding to the need for services or to a specific problem; and then recovery, which is keeping people healthy once their problems have been stabilized. And so you'll see in the middle the 3 fat green bars, or the fat green bar with 4 different colors illustrates that continuum of care. And underneath that, we've identified 3 gaps under prevention, 2 gaps under intervention, 3 under treatment, and 2 under recovery. But I think equally importantly are the things that this group probably knows better than any of us, that there's the things, the bricks, the services that are important, but the things that bind those together, what we call system enablers in this context, are the things that that really make it feel like a safety net or a system of care rather than just a set of individual things. And so we identify these system enablers like collaboration and connecting people across providers. So not just what do you get when you're within a provider, but if you have needs that expand across providers, are you getting those things? And so these system enablers, we think, are particularly important to address some of the more salient problems that have been identified by people on your island or through the data, which is if you can't get, I think as I mentioned earlier, if you can't get routine care for like an outpatient appointment, or you can't get your medication refilled on a timely basis, or you can't afford your medication, that you end up in crisis more often. Then it's more likely that somebody's going to end up in crisis or end up needing inpatient care. And that if, as the system can shift a little bit further upstream in terms of making sure people have access to routine care, that will help with the already stretched, not as much stretched crisis services, but that the kind of patient experience that occurs when somebody has to go off island, leave their family, leave their homes in order to get services, or continues to be cycling through emergency settings, which isn't the best kind of care. So these system enablers are really the strong glue that keeps the system together. And without those, what we've heard is that people experience a great deal of frustration, providers experience unnecessary work, and there's unnecessary costs for the system. So as we look at these system enablers, the way we think of those is that there are things that kind of prop up the entire system, ensuring that people get what they need and that they get what they need when they need it in order to avoid unnecessary moves to higher levels of care. So they include some higher levels of care in our sort of buckets, but the point is that that you want to get, that what we're trying to accomplish or what we've heard is lacking is an effort to get somebody the lowest level of care that they need. So that might be high intensity, intensive outpatient or partial hospitalization or other kinds of things for a certain population. But what that would be doing is preventing a crisis situation. So I think that covers, I'm not going to read each of these. You all can read, and we'll talk a little bit more in subsequent slides about how we're thinking about you might tackle those things.
Yeah, thanks, Nancy. And I'll reiterate too that the full report contains a section for each one of those bulleted points on here. So there's a lot more information, more data, a lot more ideas, specific ideas around how to address that specific component or idea as well. Okay. All right, so where do we go from here? And there are a lot of different ways to go. There's a lot to tackle, and our team has come up with a summary here of potential initiatives and potential strategies to sort of really serve as a jumping off point for the island, for the community. And we'll talk a little bit about what we have here. There are 6 ideas, sort of 6 main ideas here. And there's detail, the way this report is laid out when you get your hands on it. As you can see on the left-hand side there, there's a specific initiative and where we think it links to specific gaps or specific sections of the report, we sort of labeled them with a corresponding label from the previous page. So when you get your hands, you can able to kind of pour through it, you'll see how and where we think these things fit together a bit more in a bit more detail. But I want to just say here too, we have not fully developed, these are not comprehensive initiatives, there's not comprehensive strategies, and they're not fully baked ideas. As a matter of fact, we know very well that there's a lot of really good tactical, practical, short-term things that might be implementable. And we also know there are much longer ranging system designing type activities that need to be happening as well, more in the transformational phase of things. And that, so to harken back to what Jackie said about a multi-phase effort, that is really the work of the next phase. That is the work of intentional design, intentional initiative shaping. That is the work of resourcing, costing. What do we actually want to do about these specific things? So what we've done in the interim is just give you something to think about, something to start thinking about, something to start forming ideas around, start forming strategies around. And at a very high level, here's what they are. We think that it would be really important and necessary to empower, either by creating, identifying, maybe restructuring an organization or a group of leaders who can really lead the integration of the behavioral health system of care, focusing very clearly on those system enablers that Nancy was just talking about, those mortars, those things that bind the system together. We think it's important to be very intentional and focused around standing that up and implementing a thoughtful, deliberate process with strategies, targets, and goals around what do we want from the system? How can we enforce collaboration and support collaboration? How can we collect data and use it to make improvements on an ongoing basis, et cetera? The second thing is all around addressing that provider gap. So those couple slides ago, that is an imminent need in Nantucket. And so recognizing that there are some realities in the ebbs and flows of the workforce on and off the island, accessibility to people come and then they leave. So really getting creative about how to enhance access to providers, but really oriented around the specific needs of the community. So getting back in touch with that regular health needs assessment that happens on an annual basis or an every other year basis, really connecting with the data, really connecting with the community, and then creating a system of integrated care that is flexible or agile enough to address the needs and get real creative about how we accessing the providers. Okay. The third thing is really orienting around redesigning the crisis response system. So we're looking here, and we heard a lot about this, looking for a unified response that's blind to payer, resource to stabilize people in the least restrictive settings, to Nancy's point. And at the same time, really enhancing those school-based resources and supports to meet the needs of the youth and families with linguistic and cultural competency, but looking again at those data sources. What are the kids telling us themselves? What are our providers and our teachers and our families noticing and observing? What are they telling us? And designing our supports around that. Really targeting efforts at syncing up the connections between the school-based and community-based care. The fourth thing here is looking at intensive treatment and reintegration supports. Again, to Nancy's point, something we heard over and over and over again from providers and the community members themselves, that the resources and services available to step people up in care and then back down again are lacking. So we'd be looking and encouraging you to think about how you could go for more on-island stabilization and treatment before off-island transport and inpatient treatment is required. The fifth idea is really, once we understand and have designed a service for the community needs themselves, then think about building or modifying facilities to meet the needs of the community. Sometimes that means looking for, access to rooms and locations for recovery and social activities. Sometimes that means looking at non-traditional facilities. Sometimes that might mean looking at, transitional housing, those kinds of ideas. So looking at your facility, your infrastructure, your physical infrastructure in terms of housing and supporting services. And then the last thing that we'll say, and I know you all will say this too, that we know prevention and effective recovery is really where it's at. So promoting as much active work here as possible, really investing in ways that are proven, that are evidence-based, and really targeting efforts to reduce stigma, what Nancy talked about when we heard it from our community respondents, really increasing awareness of both behavioral health generally, as well as resources. Like that is the work of NAMI, so I know you feel this very closely. And then looking very intentionally in very different ways, very creative ways to increase the community engagement and increase the reach into communities who are needing supports and services. So a last body of thoughts here. And then we'll hold open some space for questions and comments and dialogue, of course. We have a couple other sort of closing thoughts for you, and I'm going to pause on this slide and just share them with you verbally. A couple of things. You have, in Nantucket, you have several small organizations trying to serve a relatively small population, and doing that requires quite a lot of cooperation across missions and organizational boundaries. And sometimes that can be challenging. In some cases, we've got dynamic of really incredible cooperation. And in other instances, we have a dynamic what feels more like competition. So really, focusing, like laser focus on getting that cross-system coordination and collaboration in line is going to be key. We'll say it one more time. We are humble about how we were not successful in engaging communities of color on the island. We tried again, and lots of you helped us. You gave us good ideas. You actually helped us with like boots on the ground efforts to do that. But we just know, and we know the community knows, and the leaders in the system need to know that much more work needs to be done to identify the right trust channels to get people to the table for any future planning effort. And the last thought here I'll share with you before we start chatting in a bit more informal way is that, again, we've emphasized this a couple times. We think it's really important to design a system of care. And so we've recommended a couple of very tactical things. The first is to identify a small group of leaders who are going to drive it forward, balance passion and persistent focus, who will avail themselves of off-island expertise in areas like treatment, regulatory structure, reimbursements, and community organization. Is all the idea of getting form and function in alignment. And there's really good news here, because since we have finalized this report, since we met with the steering committee, community leaders have come together from Fairwinds, the town, the community foundation, the hospital, and NAMI to create that exact structure needed to support the design and implementation of specific initiatives. This is in flight right now. So we're in this interesting gray space, right? Where we are transitioning from what does the landscape look like into now what do we want to do about it? And the gray space really is oriented around designing, coming together, coalescing, and being very organized about how to do that. So we know that in the very near future, there'll be more organized and specific communication about what that specifically looks like. When Jean introduced herself earlier today, she mentioned that she's been, we sort of convinced her to come online and help do a little bit of shepherding. She, together with Michael Kellerman, formerly of Fairwinds, will be spearheading the organization of that next phase and getting a lot of that planning on the ground and up and running. So that is a positive and very exciting next step. Okay, let me pause there. What questions, what comments? Nancy, would you add anything else before I open it up for questions or comments? No? Okay, Jackie, how about you as one of our, or Chris as part of our leadership team? Any other comments you'd like to share before we open up to the broader group?
I can say that looking at it from my point of view, which is kind of an overview, because NAMI tries to use all the services to provide a line or a continuum of care for people that come to us, that I do think that, I mean, when we talk about building services, there are always a lot of economic barriers. And on Nantucket, as we all know, housing is a huge one. People can't necessarily afford to live on the island, that we really need there to do things. But there are some things in this plan where I think that we can make progress, things that don't really cost money. And I think one of them was one of the comments that Laura just made, is that we can make an effort. And I really think that this organization, which has been in existence for a while, the Behavioral Health Provider Group, is one that can take a lead role in that communication, referral, working together, get rid of any competitive spirit, and say, we're all in this together. We all have a place, we all have lanes to be in, and let's work together and educate each other about what each one of us does. I was shocked to find out that some organizations on the island don't really know what the other organizations do. And so therefore it would be very difficult to refer services if you're not sure. So I'm hoping that this group that's now under us, it will be a priority to try to work on that piece of it, which doesn't cost money, but does address one of the issues that we've seen on the island.
Yeah, thank you, Jackie.
I thought it was a great presentation, Laura and Nancy. Thank you. And obviously a lot of great work done. I guess I'll just, from the hospital's perspective, we're really pleased with the work done today. We're super excited about the path forward. We're definitely all in. It's part of our core strategic plan to be a good partner as part of this. We know that we're only part of the solution and that being a good partner is going to be the key part. But Gary Shaw is dedicated to, putting his focus against this and being part of the team that works on the system design. And we're hopeful that, I agree with everything Jackie just said, certainly about things that can be done quickly and at low cost, but we also think there's a responsibility to think big here and think about things that will cost and how we're going to get there and do those things. And I can just tell you the hospital, I think you all know, we have a long history of tending to other areas that we needed to in our history, but this is something that is core to supporting our strategy going forward. So look for us to be a fully all-in participant.
Thank you, Chris. What questions can we answer? Or for those of you, which is many of you on the line today, any comments or initial reactions that you'd like to share from the process or from what you heard today?
Hi, this is Brian. Can you go back to the bar chart that had the two ranges for Nantucket in terms of the provider to population ratio? This one.
Yes.
So I see that it's coded green, yellow, and red.
Mm-hmm.
Are there standards that have been set nationally to describe, I guess it's okay, pretty good, or terrible, whatever those standards are? Could you explain those?
Yeah, sure. So the short answer is there are not necessarily standards. There are sort of bands of what feels like represents a healthy density in a given population. So anything under the 1 to 200 range, 1 to 210 is considered sort of in that greenish zone. That feels reasonable by this particular data set. Anything really much past the 1 to 250, so that yellow bar is right at that line, is sort of in the space where most communities, most academic researchers, most organizational system-wide level people start thinking like we need to start really focusing efforts on making sure we've got sufficient number of providers to meet the needs of this population. And so that's why we wanted to show sort of that yellow bar is best case scenario for Nantucket. And even there, it's not very healthy. When you look at what's probably realistic, you've got a clearer picture there.
Okay, that's very helpful that there are no standards per se. It's based on experiential data and comparisons of the correct provider to population ratios.
Right.
Okay. Right. Now, is there any research on what it takes with the kind of investment that's required to close the gap from 370 to get us to even to 200?
Yeah, well, I mean, is there research about that? What it would take to get us there? That's a good question. Nancy, do you have a perspective on a research basis for that?
I don't know that anyone has cracked that nut. There are a lot of ideas about how individual strategies, and to some degree, this is sort of a gross measure, right? Because there are standards for psychiatry, and there are standards for psychologists, for social workers, et cetera. So within this gross measure, there are subsets of professionals that are needed. And I think the other thing that makes this a bit fluid and a bit both presents additional challenges, but also additional opportunities, is post-pandemic, the change in the use and adoption of telehealth makes a huge difference here. And while there are more challenges in terms of need have growing, we know that nationwide, that the perceived need for mental health services and substance use services is growing. We also know that the adoption of telehealth, both from providers as well as patients, has increased. So I do think this is a baseline to use to capture what the community believes is a problem, right? I mean, it perceives as a problem. And there needs to be efforts to expand these numbers or reduce these ratios. And those should be tackled in a somewhat individual way. But telehealth provides a lot of the opportunity here, especially given some of the remoteness of the island. I think it has a tremendous amount of potential if used wisely, right? It's not the answer for everyone, and it's not in isolation. A telehealth appointment for people with very serious illnesses may not be the answer, but in combination with in-person care, you can get the right level of provider available with the support from another provider in person to do some of the things that have to be done locally, like figuring out where the resources are locally and providing recovery support services and some of those things. So that's a long way to say, no, we really don't, we really don't. There isn't any good research that I'm aware of on those specifics.
Thank you. And then one more question, since we kind of felt, at least you expressed that we perhaps did not connect with as many families of color or from other countries. Is that also baked into that 370 number? Or I guess what I'm trying to ask is, does the mix of people have anything to do with the 370, or is it just purely just one person of population? There's no analysis of the population in terms of economics or that would drive a higher need for these services. I'm not phrasing that very well. I hope you can help.
Well, I think I can understand, and I'll give the first answer. Nancy, you can backstop me here. So the first answer is the numbers here are really just straight line data. There are no sort of breakdowns by income or age or gender or ethnicity in this data set. However, one of the specific gaps that we identified and spent a section talking about is getting to the point that you are getting at, Brian, which is the current existing provider basis, the provider group does not necessarily reflect the population in its full diversity and needs as it exists right now. And that is something that needs to be addressed and needs to be targeted. And we've suggested, with the help of our advisory team and our steering committee, different ways to think about doing that. But that is absolutely a consideration. But for this data here, this is a straight sort of one for one.
Right, and that includes language accessibility as well as culturally responsive services.
Thank you. You were able to figure out what I was saying and then answer it.
It's a good question. What else? Any other thoughts? I want to be respectful of your time. I know you may have other items on your agenda.
Nancy, there is one thing I wanted to bring up. We just got the latest copy of the NAMI National magazine, and in March and April of 2021, so this is recent data. I don't know if you've seen it. I don't know how checked you are with NAMI National, but they did a survey of 4,000 people, and on mood disorders, and we were talking about telehealth, and during the pandemic, apparently the people that answered this question had received telehealth for various mood disorders, and 82% said that they would receive more mental health treatment if telehealth were always an option. 79% said it's made it easier for them to access mental health care. And 58% said, I do not think healthcare provided via telehealth is as good as in person. So I think what it says is that there is a broader acceptance to telehealth. And in our business, I think that probably a hybrid is really good, because from what I've talked to a couple of psychiatrists that work with us, telehealth can be very good and convenient, especially for somewhere like the Cape and Islands, because the Cape has a population, the Cape is 80 miles long. And so to get to one place to the other, especially, and a lot of people are elderly, what we've found is that if you have your first appointment perhaps in person, and so you kind of get to know your therapist, or if you have a therapist that you know and trust, then going on telehealth makes a lot of sense to you. So that's kind of the hybrid model, which we've found doing Zoom with even our programming, is the fact that if we can do a hybrid, that seems to really work, and especially with places that have distance problems. And of course, Nantucket has the ultimate distance problem. So I do think that Nantucket probably, when we design that system of care, that telehealth can become a fairly important factor. That's just my opinion at this point, based on data I'm seeing. And this is recent data. This was done during right after pandemic.
Yeah, Becky, I haven't seen that particular study, but everything that there's a lot of research that's been coming out, emerging about this topic, and it all points to the same thing, that surprisingly populations like people of color and in fairly historically isolated groups are more adaptable to telehealth than us as providers would ever anticipate. So, and that these blended models of delivery are really seen as the sort of the future.
I also think that maybe telehealth on Nantucket, whether, we talk about stigma and the difficulty with privacy, like if you're seen at the door of Gosnold or Fairwinds or wherever, you're apt to be seen by somebody you meet in the grocery store every day or whatever, where with telehealth, you could access it from the privacy of your own home too. Yeah. I think that could be a piece also.
Okay, any other comments, questions? Anybody else from the group on the line here wanna?
I'd like to ask a question to this group. I've, as NAMI has been involved in this from the get-go, as has Chris from the hospital and Amanda from Fairwinds, as well as the foundation. We're putting this out now, and anytime you put something out that's been kind of explored or tried before, people say, oh yeah, another crack at it. So I just want to say that I would like to know, and you don't have to say it now, but I would like to know what your doubts are that we're going to be able to pull this off this time on the island. And I think we need to be very frank about all those things. We can't, be Pollyanna about this. This is a huge undertaking. If we were to get a really good model of a continuum of care for mental health, I'm beginning to think we might be the first in the nation to have one. I mean, it's a huge, huge challenge, and we know that. But, if there are doubts, if you see problems with what we've said, we, the leaders of this thing, need to know about it. Don't just sit there and say, this is not going to work, and sit on your hands. Let's come out and really make this happen and talk about it. That's kind of all I have to say about it.
I see Brooke raised her hand.
Hi. I think perhaps one of the most important things that needs to happen is an opportunity for the leaders of the individual organizations to speak, not in a group setting, about their fears and concerns. I think it's very hard to attend these meetings and really tap into concerns and fears about change and what it might mean for individual organizations that have invested an enormous amount of resources, both in terms of their boards, their locations, their staff. And I think change is scary. You know, I work in affordable housing and it's taken us years to build some momentum in the community to accept that things have to be done differently to be successful, to really solve a major intractable problem. And I think one-on-one conversations would probably be really helpful in building trust and allowing people to articulate their concerns, not around, you know, not in this kind of a public space. It's just a thought I had. Thanks.
It's funny, something Jackie said struck with me just now, that I keep thinking, is there a model to look to help us sort ourselves out? And Jackie's suggesting no, there's no good system out there, but are there places that are doing significantly better that we could learn lessons from? I hate always reinventing the wheel, although Nantucket usually requires it.
No, and I've done quite a bit of work across states and communities, and I'll say that no community has this fixed completely, and no community is alike, and no state is alike. You know, there's varying degrees of resources and commitments and geographic challenges and all of those things. And yet there are, I think there are places to look for specific options and solutions. So for example, looking at crisis response, there are some communities that are doing really, really interesting and innovative things with crisis response. There are communities, individual providers and state, and particular individual providers and communities that are doing really, really interesting and innovative things around how they address behavioral health in emergency departments. And so I do think you can, there's opportunities to look outside to help with identifying options and solutions to specific problems. But I haven't run into a community that is sort of the panacea for how things have worked. Martha's Vineyard has done some work on some of these problems that I think could be instructional. And probably has some relevance because of some similarities in the challenges, but there's no one place that you're going to be able to look to. And that's why while we're recommending or have moved forward with a local group, local efforts and locally led initiatives, that's not to say that all ideas can or should come from within. There's a need to look outside to other experts. There's a need to get other information about policy initiatives. There's a lot going on federally. There's a lot going on at state levels around funding, refinancing, different legislative efforts that I think are opportunities. So you can't do it in isolation, but there isn't either some model to replicate.
Thank you. That's really helpful. Jason?
Yeah, Nancy, if I could jump on that. So Sue, before I started at Fairwinds, I got sent all this stuff in June. And I started reading as much as I could. And I remember watching the YouTube video from Eagle Valley, the 7-minute video of how they did it, how they designed their new system. And it didn't really stick. And I actually went back and watched it this weekend again, now that I've seen phase 2 and I've had it kind of marinate a little bit. And that was helpful, at least to see what they did over a 3-year period. And of course, like you said, Nancy, it's not going to go that way. It's going to be very different. But I think you hit it really well, Nancy. It was like, what did the Vineyard do? What was some of their challenges that we have? What was some other crisis scenarios or structures people have used? And look at how Eagle Valley did this really big, giant process and design a new system, I thought that YouTube was helpful. So I think if anybody asked me, like, what is this all about? And they only have 7 minutes to spare, I would send them the Eagle Valley video and say, we're trying to do something like that, but not exactly that.
Okay, well, barring any other comments or questions, I think Nancy and I will excuse ourselves that you have some space on your agenda without us. Again, many, many thanks to those of you who have actively been helping us pull this thing together, answering our 1,000,001 questions. Many, many thanks to you. Thanks to those of you who are here to listen to it and who will certainly be a part of any solution going forward. So our gratitude to you. Nice to see everybody and have a great afternoon.
Well,
Thanks
thank
so much to all of you.
you.
Thanks, everybody.
Does anyone else have any announcements? We have a couple minutes left till 1:30. Anything that's going on that, Sue, you want to mention Red Ribbon?
I do. So the 23rd through the 31st of October is Red Ribbon Week, which is a national campaign on substance misuse prevention. So I encourage you all to wear red ribbons. There'll be signs around the island. The select board will be reading a proclamation, and a lot of students. Hopefully you'll be getting some grocery bags at the Stop and Shop with some healthy messages and healthy ideas that the kids in art classes down at, I think, the elementary school are decorating. So it's always a treat to get those grocery bags that are all colored up and with smiley faces and happy families. So that will be exciting. And then on a sort of something I'm doing outside of the workplace is I'm on the commission, the Cape Cod and Islands Commission for the Status of Women, and we are holding a listening session a week from Saturday at 56 Center Street at 1:30 p.m. to hear about the concerns and challenges of women in the state of Massachusetts and specifically on Nantucket. And it's a great place to come and advocate for behavioral health needs on Nantucket. The commission will bring our findings to the state level and talk to our representatives about what the women and families of Nantucket need. So I encourage anyone, women particularly, to come and offer testimony, whether it's access to healthcare or affordable housing, whatever the needs are. That's what the commission would like to hear about. That's my update.
Anyone else have an update from their organization?
Sure, I have a quick announcement from Children's Cove. Hello, everyone. So just an update that we do have our Champions for Children conference next Thursday. That's October 21st. If anyone hasn't had a chance to look at that, you can go to the championsforchildrenconference.com website. We're doing that for free this year, so there's no cost. It's a free all-day conference as well as free CEUs, 5.5 CEUs for anyone that needs those. That's an LICSW, LCSW, or LMHC. So hope to see some of you join us.
Anyone else? Well, in that case, it's about what, 1:15? So if no one else has anything to say, perhaps we can end the meeting and we'll see you again in November. Thank you very much for attending. And Sue, make sure that we have a list of everyone that attended, please. And remember, this has been recorded. So if there are other people that you think want to see this presentation, please let us know because it will be available. So thank you and have a nice rest of this really pretty day.
Thank you, Jackie.